this was the anatomy of the fistula. So this was lateral sacral artery, and this was phylum terminal vein. So this is the microcatheter run showing the same, and we embolized it with squid 12, which is EVOH. So we can, like, there are options of embolizing it with glue also, but we went ahead with squid 12 is relatively less viscosity, so it percolates well, and this is post embolization, showed complete exclusion of fistula. And this is the post embolization done, showing fistula is completely gone, well percolated to the venous footprint, and we did see to demonstrate the same. So here in axial we are seeing that it is percolated within the vein much beyond the fistulous point, and here we can see the neural foraminal branch of lateral sacral artery supplying the fistula. And this is the 3-month follow-up. So this is the pre-procedure MRI, and this is the post-procedure MRI. We can see that there is complete resolution of spinal cord edema. We are no longer seeing any flow voids, and the amino log grading also improved of the patient. Now patient was initially requiring walker for move around, and now he needs one stick to move. So I mean, at 6 months follow-up, we have 6 months follow-up also, like patient is like completely, like he has shifted to amino log grade 2 now. So coming to the second case, this is a moderate flow sacral DAVF. So this is like will come in next subsequent slides that why it is a moderate flow fistula. So this presentation is more or less the same. There was ascending asymmetric paraparesis, and unfortunately this patient had severe bladder involvement, so there was complete incontinence to begin with, and bilateral lower limb power was also 1/5. So the amino log grade was grade 5, which is highest. So patient was completely confined to bed and wheelchair, and maturation there was complete urinary incontinence. So patient was not so cooperative, so we could do very limited sequencing. So we can see here there is spinal cord edema, but there was a clinch that here we could see. We had doubt that there are some flow voids which are very, I mean, not so prominent as the previous case, but we had a doubt that there is a fistula. So now coming to we did angiogram. So it's not that we did only internal iliac like we do all segments, but here we can see that the fistula is not so aptly seen. It is very faintly visualized here. Here we can see that it is very faintly filling. So we did a guiding catheter angiogram, and that also the fistula was here we can see very faintly filling, so it is quite possible that one may miss it. And then we went ahead with microcatheter, and we did a microcatheter injection, and here we can see now the fistula is very well demonstrated. So coming to anatomical aspects, so in non-selective or relatively less selective angiogram, it was very faintly visualized, and in microcatheter injection you can see the anatomy very nicely, that this is lateral sacral artery fistulous point followed by phylum terminal vein. So in this case also we went ahead by embolizing it with squid, and here we can see that squid cast, it has perforated till the venous footprint, and post embolization angiogram did not show any residual fistula. So this is, I am playing the post angiogram. Anyways, it was very faintly filling, but now it is not, I mean, we are sure that it is not filling now. And this is the CT to show the percolation. So here we can see it has started, I mean, it has percolated very well. We can see in much cranial sections also. Here it is demonstrating the neural foraminal anatomy of lateral sacral artery. So it was very well percolated, and I have seen, I mean, at 3-month follow-up there was mild improvement in power, I mean 2/5, but the functional grading was same. Patient was still not able to move around by walker or anything. He was still confined to bed. There was no improvement in maturation. So generally the later stage of fistula, they don't recover so well as compared to the early stage of treatment. but MRI showed, on the contrary, quite significant improvement. So here we can see that there is edema, and in later MR imaging there is significant reduction of fistula, and now we are not seeing much of the flow voids. And coming to the third case, which is slow flow sacral DAVF. So this patient had just low backache, and neurologically patient was completely fine. So he actually underwent MRI for low backache, and here we are seeing on MRI that there are flow voids which are quite prominent, but there is no cord edema. So this is quite an early pickup of sacral dural AV fistula. So we went ahead with angiogram. We did, I did complete angiogram, and I could not find any of the, I could not find any fistula. So I am showing the internal iliac vein. This is right internal iliac vein, and this is left internal iliac vein. So like from dorsal, cervical, everything was done, but still I had very strong suspicion that there is a fistula. So I decided to repeat the fistula with repeat the angiogram with microcatheter in lower lumbar and sacral level, and I am just showing the microcatheter injection of right lateral sacral artery. Here we can see very faint filling of fistula, and it was there actually. So this was like quite tough to pick up case, and this is the anatomy. So these are the tiny ramified feeders coming from lateral sacral artery. This is phylum terminal vein, and actually it was not draining into the perimedullary venous plexus, rather it was draining into the radiculomedullary vein to extradural part, which was actually preventing the spinal cord edema to form. So I don't know how long this radiculomedullary vein would keep on working as alternate path to prevent spinal cord edema. So there is no data regarding conservative management of sacral dural AV fistula, and this is such a low flow fistula. So as patient did not have any neurological deficit, or patient was completely neurologically normal, so we gave him option of clinical follow-up versus endovascular embolization. So he opted for follow-up. So we had 6-month follow-up of this patient, and patient had completely stable course. But we don't know actually if patient may end up with neurological deficit, only time may tell this. So this is just a brief discussion of sacral dural fistula. So like the largest case series published is of 13 paper, and they had embolized 8 patients with glue, and rest of the patients were treated surgically. So like there are endovascular versus surgical option. Both options are quite good. And endovascularly also, like glue versus EVOH. So like EVOH, there are few case reports, but in my experience it works very well. So the take home message is that these fistulas are like quite easily missed because they are supplied by internal iliac artery. We need to do very selective angiogram of internal iliac artery. Sometimes in high suspicion we have to do angiogram of with microcatheter in lateral sacral artery, and the EVOH actually the previous paper, which is the largest series, they have said that it does not work so well, but in like we have seen in many cases that it works equally well, just like glue. So yeah, that's it. Thank you so much.
Thank you, Dr. Nihar. A very nice presentation. The paper is open for discussion. So Nihar, I would like to ask you one thing, just for the, so that I think there are some young neurointerventionists in the audience. So what is the end point of embolization of this sacral AVMs? So like when you do a microcatheter shoot, so what is your end point?
Like once it starts percolating to venous side, that's the end point in this fistula.
Yeah. So this is a very important point that Nihar has made. So you don't, whenever you embolize, you have to reach the venous, you have to capture the vein. It's not that if you just capture the fistulous point and stay there, then it is 100% going to recur.
Yeah.
So you have to capture the vein when you are embolizing such sacral dural AV fistulas.
So
Very-
like if we don't embolize the vein, then like there are almost 70-80% chances that it would recur. So with glue, the success rate is almost 80-90%. Same I have found it with squid or onyx. And surgery, like if surgery also, like one has to exclude the venous component. So if surgically it is excluded, then it's 100%.
Yeah. Thank you. Thank you, Dr. Nihar. May I now take the opportunity to invite Dr. Richa Singh. She is Assistant Professor in the Department of Radiology, AIIMS, Raipur. She is going to speak on direct percutaneous embolization of spinal epidural AV fistula, a technical consideration.
Good morning, everyone, and I would like to thank the organizers for having me here today. I will be talking today about a very rare entity, that is spinal epidural arteriovenous fistula, SEDAVF. The entity is that rare that in the initial classification of spinal vascular malformations, they did not even include this in the classification, and the classification only consisted of the dural AV fistulas, the glomus and the juvenile AVMs, and the perimedullary AV fistulas. But recently they have included this entity as a type 5 spinal vascular malformation. So this malformation is very rare, and as the name suggests, a malformation, it is an abnormal communication between the dorsal somatic artery and the ventral epidural venous plexus. So first, before going ahead directly to the treatment of this entity, I would like to brief about the epidural AV fistula first in my first few slides. So it's an abnormal communication, as I told, between the dorsal somatic artery and the ventral epidural venous plexus. The other communication can also exist depending upon the location of the fistula along the spinal vertebral column, that is whether it is cervical or thoracic, or it is lumbar, or it is sacral. So in the lower thoracic and the lumbar regions, the most common artery which is involved is the dorsal somatic artery or the ventral somatic artery. However, if we go down along the sacral side, that there is the lateral sacral artery which contributes to the fistula, and if we go higher up, there may be branches of ascending or the deep cervical artery, as well as the vertebral artery itself or the branches of the vertebral artery which can contribute to the epidural AV fistula or the vertebral arteriovenous fistula. Now the most important point regarding the SEDAVF is the presence of epidural venous pouch. So as opposed to the other kind of AV fistulas where the artery directly communicates to a vein, here we have a intervening big epidural venous pouch. I'll be showing by the schematics as well as by the DSA images later that this pouch is so much important that when we see this pouch, even on the MRI, we can surely say that yeah, we are dealing with a epidural AV fistula. Other than that, the other important point is that this fistula is usually having, like in more than 80-90% of the cases, it has multiple feeders. It's not a single artery and a single vein which is involved here. The epidural venous pouch might have multiple arterial feeders, and along with it, there can be multiple draining veins as well. Usually, the epidural venous fistula, it drains into the epidural venous plexus or the paravertebral venous plexus, and further into the veins like azygous vein or the lumbar veins, depending upon the lumbar level or the thoracic level of the fistula, or in the jugular system in the cervical region, and and the sacral fistula also, it drains into the paravertebral venous system. So just to show a brief anatomy of spinal vasculature just pertaining to the epidural AV fistula, the segmental artery, it arises from the aorta, it goes posteriorly. it divides into the ventral and the dorsal branches. The dorsal branch further gives the spino-radicular branches. The spinal radicular branches gives the spinal branches, that is anterior and the posterior epidural veins, and the radicular branch which goes intradurally. This anterior epidural vein, it goes to the anterior epidural plexus, arterial plexus, which runs all the way along the vertebral column from the base of the skull up to the sacral region. And this anterior epidural artery is actually the dorsal somatic artery, which contributes most commonly in the formation of epidural fistulas. This artery is most common contributing artery, but the other arteries also contribute. The ventral somatic artery, which directly supplies the vertebral body, and the other arteries which I mentioned previously. Now we will focus only to the epidural space. So this is a schematic of a spinal epidural fistula. This is the segmental artery. It gives off a dorsal somatic artery, and this entire thing, which, sorry, I'm so sorry. And yeah, this entire thing is the venous pouch, which is lying ventrally within the spinal canal. As we see in the axial section, this pouch lies ventrally and laterally. Now further, this pouch is giving off the epidural vein, and in some of the cases of the epidural fistula, we can see that after the pressure rises, it can lead to the opacification because of the negative pressure, the pressure changes. It can lead to intradural drainage also, and like in dural fistulas, we can have a paramedullary vein, a prominent paramedullary vein, and prominent flow voids along the dorsal surface of the cord, as we see in the dural AV fistulas. So sometimes it becomes difficult on MRI and CT to differentiate between the epidural and the dural AV fistulas. But the presence of this venous pouch is very important, and it points out that we are dealing with a SCDAVF. Again here, this is the pouch, and this is draining into the epidural vein, which is going all along in the draining into the paramedullary vein, and which is seen here as a prominent vein between these nerve roots. Now, location-wise, these fistulas can be of two types, the ventral or the lateral fistula. And this location also depends upon where exactly the epidural pouch is prominent. So, in the lower thoracic and the lumbar spine, the epidural pouch or the ventral epidural space, it is prominent anteriorly, because it has a lot of space there. However, in the cervical and upper thoracic region, the epidural space is more prominent off midline or laterally, because there is a thick PLL, posterior longitudinal ligament, in the cervical and the upper thoracic region. So depending upon that, the fistula location also can be ventral or lateral. Now types, there are two types. As I told earlier, that certain fistula can drain intradurally, so with or without intradural drainage. Now this is very important. Why? Because the age of presentation and the clinical presentation of the patient depends whether the fistula is draining intradurally or not. So pathophysiologically, if the fistula drains intradurally, it goes with a slow course, and the symptoms happen because of the medullary venous hypertension, as we see in a dural AV fistula. While if the patient presents with a large epidural venous pouch without intramedullary drainage, the symptoms are because of the mass effect of that pouch, which is compressing the cord and is causing myeloradiculopathy. The age of presentation also is related with this, because if the epidural pouch is very large, the age of presentation will be early. The patient will present in the 20s, early 20s or 30s. However, if it presents with the venous hypertension because of the intradural drainage, the age of presentation will be in 60s. So the common presentation would be the sensory symptoms, the motor symptoms, as well as the involvement of the bladder bowel. Now imaging, we can do MRI or CT, as in all cases of motor and sensory disturbances of lower limb paresthesias or motor power loss we do. But the most important point here would be the presence of the epidural venous pouch, which we can see in 80–90% of the cases on MRI, and the flow voids along the dorsal surface if the fistula is draining intradurally. The cord changes can also be present. In CT angio, we can see only this venous pouch, the cord changes and the flow voids we might not see that nicely. But the DSA is gold standard, so anyways if we are suspecting a spinal vascular malformation, we have to go for a catheter angiography or a diagnostic DSA, which can tell about the angioarchitecture of the lesion as well as the drainage pattern of the lesion, and we can plan our treatment protocol accordingly. So treatment options can be many, the endovascular route or the microsurgery. Endovascular options can be transarterial approach or transvenous approach or a combined approach. But today I am talking here about a novel technique, that is direct percutaneous access of this epidural venous pouch, which we see in cases of these fistulas. So percutaneous embolization, we have treated 2 cases of spinal epidural AV fistulas with this percutaneous embolization, and the patient had significant clinical improvement, both the patients. We have got our cases published in JVIR also. So first case, he was a 16-year male who presented with progressive motor and sensory symptoms as well as bladder and bowel dysfunction for 6 months. And when he came to us, we did an MRI. So here we can see these are the axial, coronal and the sagittal images of the MRI, and this is the MR angio. So we are seeing here that this is a large flow void in the ventrolateral aspect. This is D7 level. So this is a large flow void, this is that pouch which I was mentioning again and again. This is the epidural venous lake or epidural venous pouch, which is the most commonly seen or is seen in almost all the cases of SCD-AVFs. So what we are seeing here, that this pouch is causing mass effect on the cord. It is displacing the cord, and on the sagittal section we can see that there are signal changes also in the cord. Other than that, we are seeing multiple flow voids along the dorsal surface of the cord. But in this particular case, these flow voids were not due to the SCD-AVF. This patient actually had 2 different malformations in one case. This is the MR angio image, we are seeing the epidural venous pouch. So what was that other malformation? This patient also had a perimedullary AV fistula along with epidural AV fistula. So this is the right D7 antero-posterior and lateral view, the left D7 antero-posterior and lateral view, and we see that this is the epidural venous pouch which I was talking about. This is the diagnostic catheter, this is the segmental artery, and this is the dorsal somatic artery which is feeding this epidural venous pouch. On the lateral also we are seeing that this is the segmental artery, the dorsal somatic artery which is feeding this epidural venous pouch. As I told, there can be multiple feeders. We did all the runs and we found that left D7, the right D4 and the left D4 were also feeding the fistula. On left T8 injection, we saw that there was a perimedullary fistula which was filled by, this is the anterior spinal artery, and there were flow voids at the level of D4 vertebra. So these flow voids, veins, the prominent veins which we are seeing here, they were the result of, they were causing those flow voids which we were seeing on MRI. The SCDF per se was not having any intradural drainage. So since the sac was large, it was decided to treat the SCD-AVF first and do the interval treatment of perimedullary fistula if at all it was required. So first we approached the SCD-AVF with the percutaneous approach. In that what we did, the sac was directly approached with a IV cannula, 18 gauge, that green colored IV cannula, and it was used to directly puncture and to approach the sac. And through that cannula, we took the microcatheter within that sac, and through that microcatheter, we put some coils within the sac, and then we injected glue within the sac. So this is the glue cast which we are seeing, and retrograde filling of the various feeders which are also seen. And this is the expert CT image, the axial section where we are seeing the coil and the glue cast, and this is the post embolization angio run where we are seeing that there is no fistula from the right D7 level. So what we did actually was, when the patient was supine, we hooked the most prominent feeder to the fistula. In this case it was right D7. So we placed the diagnostic catheter only at the right D7, and then we clamped the catheter. We sutured the catheter in place on the thigh of the patient. We turned the patient to the prone position, and from the posterior aspect, we directly punctured the fistula through a IV cannula and then embolized the fistula. So this is the post treatment MRI after 6 months. So what we are seeing here, the flow voids are still persistent because we did not touch the perimedullary fistula. However, there is significant resolution of the cord symptoms. The cord has been located in its normal position. It is not displaced now, and the epidural venous pouch is gone. This is the magnetic resonance angiographic image. The sagittal and the axial ones, we are not seeing any pouch now. The patient, after 2 years of follow-up, showed almost complete resolution of the symptoms. So we decided not to treat the perimedullary venous fistula. The second case, he was also young. As I told that if the patient presents with a prominent pouch, they usually present in their 30s. So he was 26-year male who presented with progressive motor symptoms and sensory symptoms for 8 months. There was no bladder bowel involvement in this patient. This is the MRI of that patient, the sagittal axial images, and we can see that there is a small pouch here on this sagittal image which is causing vertebral body scalloping, and there are cord signal changes in this case. In the axial section, we can see that this is the prominent flow void, which is the epidural venous lake, which we are seeing here, and the cord is displaced contralaterally. On the sagittal CT, we can see that because of these vascular channels, there is scalloping as well as erosions of the posterior column and the erosions along the vertebral body, the dorsal surface of the vertebral body. These are the angiographic images at the right and the left D9 level. So the right D9, this is the dorsal somatic artery which is going to the fistula, and this is the left D9 level. We can see that this is a dorsal somatic artery and this is the ventral somatic artery, and both are contributing to the fistula. So coming to the treatment part, again we cannulated through a 18 gauge cannula. We put microcatheter, we can see the microcatheter here. Then we put a single coil and glue within the sac through that microcatheter, and the glue was allowed to reflux within all the feeders which were supplying that epidural venous pouch. This is the post embolization run. We are seeing the fistula is completely excluded, and this is the CT topogram. We are seeing that this is the glue and the coil cast, and this is the sagittal image of the CT in bone window. We are seeing that this is the glue within the epidural venous pouch and at the fistulous point. This is a 3-month follow-up MRI of this patient. We are seeing that there is no mass effect on the cord now. The cord signal changes have gone, and the epidural venous pouch is also, we can see here, there is no flow void now here. So epidural venous pouch has also gone. However, in this particular case, what happened that when this sac was embolized, so because of the sudden thrombosis of the sac, there was a lot of mass effect and inflammation around the sac, which led to complete motor loss in the patient immediate post procedure. So patient had to undergo laminectomy because of that. However, after laminectomy, after a few days, like 1 month of laminectomy, the patient's motor power, patient came 5 by 5, and the sensory symptoms also were resolved. So these are the post-treatment, post-laminectomy changes in the posterior aspect. So coming to the discussion, the spinal epidural AV fistulas can be treated by endovascular or by surgical route. However, since as I told, the fistula is present ventral to the spinal cord, so the approach by surgery can be sometimes difficult. The endovascular routes can be transarterial or transvenous, but sometimes the arteries feeding to the fistulas are very small and are difficult to cannulate. As well as sometimes transvenous cannulation, the cannulation of the azygos or the lumbar veins can be quite challenging. So this direct percutaneous embolization, it is a very useful technique, as we can directly access the sac under the fluoroscopic guidance. So direct access to the pouch, it leads